Today's course is on eating disorders for nursing. My name is Dr. Sarah Smock Jordan, and I'm a licensed marriage and family therapist. We'll start by going over today's goal statement. The goal for this course is for the registered nurse to gain a greater knowledge of feeding and eating disorders, body image and obsessive-compulsive body-related disorders, and food addiction. The objectives for this course are: participants will gain a better understanding of the different types of feeding and eating disorders. Participants will learn more about body image and obsessive-compulsive body-related disorders. And participants will learn about the new research on food addiction. The importance for this course: addiction, including eating disorders, is progressive and can result in disability or premature death. Because nurses spend a great deal of time with their patients, their work is a significant part of patient care. There's a lack of research on nurses' experiences with eating disordered patients, and so this course will better inform you on working with those suffering from various types of eating disorders. Anorexia nervosa patients have a high risk for major health problems which can lead to death. Rumination disorder in infancy and childhood can lead to death if left undiagnosed and untreated. Nurses may find caring for patients with feeding and eating disorders to be challenging. Patients are often difficult to treat, uncooperative, and challenging to nurse. Nurses may struggle with understanding the complexities of these disorders, and there is a lack of research on eating disorders in nursing. Let's start by talking about addiction and defining what that is. Addiction is a primary chronic disease of brain reward, motivation, and memory. It's a dysfunction in the circuits leading to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and/or relief by substance use and other behaviors. Characterized by inability to consistently abstain, impairment in behavior control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, as well as a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission. Without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. The term addiction is not listed in the DSM-5, nor has it been listed in previous editions of the DSM. However, a lot of people may refer to food addiction or classify anorexia or bulimia as a type of addictive disease or disorder. Let's now talk about eating disorders specifically. What is an eating disorder about? It's really all about control, and it's not about food. One misconception about eating disorders is that it's all about food, and it's really not. It's about control. And control just happens to come out in terms of controlling how much one eats, how much one does not eat, relieving oneself in terms of purging food if they've eaten too much, etc. This type of disorder is very similar to OCD, which is having obsessions and compulsions. Obsessions are thoughts that a person may have over and over again about food, perhaps in this case. I'm fat, I need to watch what I'm eating, I need to be aware of how many calories are in each serving or each bite that I take perhaps. And then the compulsion is the behavior. So for those with eating disorders, they may restrict their food, they may overindulge in food, and they may purge after eating, either with vomiting or laxatives or other methods. Eating disorders also involve a sense of having euphoria. So there is a pleasure system and reward that occurs once either food is restricted or even perhaps food is purged. Eating disorders have a strong biological, psychological, and social component to them. We're now going to go over the DSM-5 diagnoses of feeding and eating disorders. We will start with going over a list of the listed feeding and eating disorders, and then we will also talk about other body image disorders listed in the DSM-5. We're going to talk about anorexia nervosa, avoidant restrictive food intake disorder, binge eating disorder, bulimia nervosa, pica, rumination disorder, other specified feeding or eating disorders, and unspecified feeding or eating disorders. Let's start with anorexia nervosa. This may be the disorder that you're most familiar with. Anorexia is usually very easy to spot because individuals suffering, especially from extreme forms of anorexia, tend to be very thin, may have hair loss, may have yellowing eyes, and a lot of other physical characteristics and traits that will let you know someone is struggling with this particular disorder. The DSM-5 lists diagnostic criteria for anorexia as restriction of energy intake relative to requirements leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Significantly low weight is defined as weight that is less than minimally normal, or for children and adolescents, less than that minimally expected. The second criteria for this disorder is an intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain even though they're at a significantly lower weight. The third criterion is disturbance in the way in which one's body weight or shape is experienced, undue influence of body or shape on self-evaluation, or persistent lack of recognition of the seriousness of the current low body weight. There are different types of anorexia nervosa. Listed in the DSM are two types of anorexia nervosa. First is the restricting type. During the last 3 months, the individual has not engaged in recurrent episodes of binge eating or purging behavior. This includes self-induced vomiting or the misuse of laxatives, diuretics, or enemas. This subtype describes presentations in which weight loss is accomplished primarily through dieting, fasting, and/or excessive exercise. The second type of subtype listed in the DSM-5 is binge eating/purging type. During the last 3 months, the individual has engaged in recurrent episodes of binge eating or purging behavior, which includes self-induced vomiting or the misuse of laxatives, diuretics, or enemas. The DSM-5 suggests that you should specify if anorexia is in partial remission or full remission. In partial remission, criterion A was met in the past, but not for a sustained period of time, but either criterion B or criterion C is still met. If an individual is in full remission, after all criteria were met, but none of the criteria have been met for a sustained period of time. There are also ways to specify the severity of anorexia. A mild version of anorexia is classified as a BMI is greater than or equal to 17 kilograms. Moderate is if you have a BMI of 16 to 16.99 kilograms. Severe is when your BMI is 15 to 15.99 kilograms. And extreme severity is when a BMI is less than 15 kilograms. When diagnosing someone with anorexia nervosa, like with other mental health disorders, it's very important to rule out some common medical conditions that can often be misdiagnosed for a mental disorder. For anorexia nervosa, the DSM lists differential diagnoses or other possible conditions that need to be ruled out, such as gastrointestinal disease, hypothyroidism, AIDS, and occult malignancies. All of these physiological disorders may have symptoms that are similar to anorexia nervosa. So again, when making any type of diagnosis for a feeding or eating disorder, especially anorexia or bulimia nervosa, it is important to do other lab works to see if there are other deficiencies, in major organ systems that are the root of the problem, not just a result of a behavior and a psychological issue. Let's talk a little bit about the physiology of anorexia. Anorexia affects several major systems of the body. The first is the endocrine system. This may be noticed by an absence or irregularity of menstrual period. Thyroid levels may also be very off and may cause hypothermia, constipation, and dry skin. One characteristic of someone with anorexia may be wearing a hooded sweatshirt in the middle of the summer, perhaps while going for a brisk walk. For most people, that would be very uncomfortable, but for someone with anorexia, they actually feel like they're at the right temperature. Electrolyte and metabolic. This can cause weakness, lethargy, cardiac arrhythmias, and vitamin deficiencies. Cardiac and cardiovascular issues can result. This will show up with a low pulse and low blood pressure. Those that use Ipecac to induce vomiting may weaken the heart, and this may be irreversible and even lead to death. Gastrointestinal issues may resulting in fullness, bloating, and constipation. And other abnormalities may be present: impaired temperature regulation, brain atrophy, and perhaps even fractures. About 0.4% of all young females meet diagnostic criteria for anorexia nervosa. Although the male prevalence is unknown, we do know that there's a 10-to-1 female to male ratio for this disorder. Usually symptoms begin in adolescence or young adulthood and rarely occur or begin after the age of 40. The crude mortality rate for this particular disorder is 5% per decade. People suffering from anorexia nervosa are often perfectionists. They have high expectations for themselves. They want to be perfect in school, work, and personal life. And culture tends to be a relevant factor as well. Anorexia nervosa is most prominent in post-industrialized and high-income countries such as the US, European countries, Australia, New Zealand, and Japan. It can also have comorbid conditions with bipolar, depressive disorder, major depressive disorder, and different types of anxiety disorders. Again, OCD, obsessive compulsive disorder, is common with the restricting type of anorexia nervosa. The next disorder that we're going to talk about is avoidant restrictive food intake disorder. The criteria are listed here, A through D. The first one is an eating disorder or feeding disturbances as manifested by persistent failure to meet appropriate nutritional and or energy needs associated with one or more of the following: significant loss of weight or failure to achieve expected weight gain or faltering growth in children, significant nutritional deficiency, dependence on enteral feeding or oral nutritional supplements, marked inference with psychosocial functioning. The second criterion is that the behavior is not better explained by lack of available food or by an associated culturally sanctioned practice. C, the behavior does not occur exclusively during the course of anorexia nervosa or bulimia nervosa, and there is no evidence of a disturbance in the way one's body, weight, or shape is experienced. And the last one, the eating disturbance is not attributed to a medical condition or better explained by another mental health disorder. When it does occur in the presence of another condition disorder, the behavior exceeds what is usually associated and warrants additional clinical attention. You should specify if, after full criteria are previously met, the criteria have not been met for a sustained period of time. Avoidant restrictive food intake disorder is equally common in females and males. It's commonly comorbid with anxiety disorders, obsessive compulsive disorder, ADHD, autism spectrum disorder, and intellectual disabilities. It can occur as early as infancy, and research shows that 5 to 14% of children and adolescents with eating disorders may meet criteria for ARFID. Now we're going to go over a case example of avoidant restrictive food intake disorder. John, aged 14, is brought in for an assessment by his mother. His mother is concerned that John didn't have a healthy diet and describes him as being a lazy eater. His diet consists of dry cereal and other carb-rich foods. He won't eat meals, but grazes sometimes. He mostly drinks Coke and lemonade, refusing anything that doesn't contain sugar. He refuses to eat fruit, vegetables, meat, and fish, and will not take a multivitamin, which he took as a younger child. His height, weight, and BMI range from the 9th to the 17th percentile. John reports being okay with his diet, and although he occasionally feels hungry, he can forget about it if he is busy playing or on the computer. He has had a recent episode of dizziness, and has a lack of energy. Academically, John functions low and only has a few friends. He is teased at school, which leads to aggressive outbursts. So this is a typical case of avoidant restrictive food intake disorder of an adolescent. We're now going to talk about binge eating disorder. The DSM-5 lists 5 criterion that should be present when giving this type of diagnosis. Recurrent episodes of binge eating should be present. An episode of binge eating is characterized by both of the following. First, eating in a discrete period of time within any 2-hour period, an amount of food that is definitely larger than most people will eat during a similar period of time and under similar circumstances. The second is a sense of lack of control over eating during the episode, so a feeling that one cannot stop eating or control how much one is eating. The second criterion is the binge eating episodes are associated with 3 or more of the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because feeling embarrassed by how much one is eating, or feeling disgusted with oneself, depressed, or very guilty afterwards. The third criterion is marked distress regarding binge eating is present. Binge eating occurs on average at least once a week for 3 months, and binge eating is not associated with recurrent use of inappropriate compulsory behaviors such as in bulimia nervosa, and does not occur exclusively during the course of bulimia nervosa or anorexia nervosa methods to compensate for overeating, such as self-induced vomiting. So the difference between binge eating disorder and bulimia nervosa is purging is not occurring. They're just eating large quantities of food without purging those afterwards. You should specify if binge eating disorder is in partial remission or in full remission. For partial remission, after full criteria for binge eating disorder were previously met, binge eating occurs at an average frequency of less than 1 episode per week for a sustained period of time. In full remission, after full criteria for binge eating disorder were previously met, none of the criteria have been met for a sustained period of time. You should also specify if this disorder is mild, moderate, severe, or extreme. A mild severity would be 1 to 3 binge eating episodes per week. Moderate would be 4 to 7 binge eating episodes per week. Severe, 8 to 13 binge eating episodes per week. And extreme would be 14 or more binge eating episodes per week. Some people with binge eating disorders may only binge on the weekends or certain days of the week. It may be very thought out, while others may binge every day, several times a day. For binge eating disorder, the 12-month prevalence rates for adults is 1.6% for females and 0.8% for males. This is a distinct disorder from obesity because most people who are obese don't engage in recurrent binge eating. Compared to weight-matched non-binge eaters, those with this disorder have greater impairment, lower quality of life, more subjective distress, and greater psychiatric comorbidity. Bulimia nervosa. This is probably the second most common eating disorder that you may be familiar with. It involves recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following: eating in a discrete period of time within a 2-hour period, an amount of food that is definitely larger than most people would eat during a similar period of time under similar circumstances, and a sense of lack of control over eating during the episodes, a feeling that one cannot stop eating or control how much one has been eating. You'll notice that this is the same criterion for a binge eating disorder. The second criterion for bulimia nervosa is recurrent inappropriate compensatory behavior in order to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, or excessive exercise. This is the difference between bulimia nervosa and binge eating disorder. Lots of different types of purging can exist. A lot of people think that it's usually vomiting or laxatives, but other things like medications, fasting, or excessive exercise may be used to purge when someone has had a period of time where they've eaten or binge on food. The third criterion is the binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. Self-evaluation is unduly influenced by body shape and weight, and the disturbance does not occur exclusively during episodes of anorexia nervosa. You should specify if this disorder is in partial remission or full remission. For partial remission, after full criteria for bulimia nervosa were previously met, some, but not all of the criteria have been met for a sustained period of time. In full remission, after full criteria for bulimia nervosa were previously met, none of the criteria have been met for a sustained period of time. There are also severities in the DSM-5 that are given for bulimia nervosa. A mild version would be an average of 1 to 3 episodes of inappropriate compensatory behavior per week. Moderate is an average of 4 to 7 episodes. Severe, an average of 8 to 13, and extreme is an average of 14 or more episodes of inappropriate compensatory behaviors per week. For bulimia nervosa, you should also rule out other physical conditions that may be occurring. One type of differential diagnosis that the DSM-5 lists for bulimia nervosa is called Kleine-Levin syndrome. This is also known as Sleeping Beauty syndrome. This is a very rare neurological sleep disorder when an individual may sleep for long periods of time. They may be appearing to sleep their life away, and this may result in episodes of binge eating as well as perhaps even purging as a result of this sleep disorder. So even though this is rare, if your patient is experiencing issues with sleep, they're sleeping a lot, they're needing to be cared for or watched while they are sleeping, then further neurological tests should be conducted to rule out this type of disorder. Let's talk a little bit about the physiology of bulimia and what it does to the body. Again, like anorexia nervosa, it affects many major systems and organs of the body. The first is the endocrine. So while with anorexia nervosa, you may have an absence of a menstrual period or irregularity. In bulimia, you could have both irregularity or absence of menstrual period. You can have an abnormal pleasure and reward response that is not characteristic of those who do not suffer from bulimia nervosa. The electrolyte and metabolic rates, you might find again electrolyte imbalances, cardiac and cardiovascular issues. Those that use Ipecac to induce vomiting may weaken the heart, again, may be irreversible and lead to death. Gastrointestinal issues, constipation and increased threshold for both pain and temperature stimuli, and other abnormalities such as EKG abnormalities may be present in those with bulimia nervosa. So if you're a nurse working in a field, maybe it's cardiac, maybe it's with an endocrinologist, you may notice some of these symptoms, and this may be, you may want to ask some questions and do some assessment to see if the person has a physiological disorder or a mental disorder such as an eating or feeding disorder, or both. Bulimia nervosa has a 12-month prevalence rate of 1 to 1.5% among young females. These are typically within normal or overweight range. Bulimia is much harder to physically recognize than anorexia nervosa because those with the bulimia are going to be of normal or slightly overweight. Usually the dentist is the first healthcare professional to find evidence of bulimia nervosa. This is due to purging. For those that induce vomiting, the acids from the stomach will wear away on the enamel of the teeth, and so those that use self-induced vomiting as a way to purge will have evidence in their teeth of these behaviors. So that's why the dentist may be one of the first health professionals to find that the person is actually suffering from bulimia nervosa. There are some gender differences. Men pay less attention to losing weight and taking diuretics or laxatives. Men fluctuate more in weight throughout their disease, and men are more interested in sports than perhaps females as a way to purge. The DSM-5 lists the next disorder as pica. Pica is a persistent eating of non-nutritive substances for a period of at least 1 month. The eating of non-nutritive substances is inappropriate to the developmental level of the individual. The eating behavior is not part of a culturally supported or socially normative practice, and if occurring in the presence of another mental disorder, such as autistic spectrum disorder, or during a medical condition such as pregnancy, it is severe enough to warrant independent clinical attention. Note that pica often occurs with other mental health disorders associated with impaired functioning. Common substances that people ingest who have pica are earth, raw starch, large quantities of ice, charcoal, ash, and chalk. Now, pica is not limited to ingesting these non-nutritive substances, but these tend to be the most common ones. Pica most often occurs with young children, pregnant women, and those with intellectual disabilities or mental disorders. Some may have a vitamin or mineral deficiency, but often no specific biological abnormalities are found. Pregnant women with pica are more likely to be iron deficient. Pica can be comorbid with trichotillomania or excoriation, and these conditions are ingesting either hair for the first one or skin by eating that. So trichotillomania is pulling one's hair, and a lot of times people will eat that hair after they have pulled it. And excoriation involves skin picking, and sometimes people ingest that skin once it has been picked. So they may be suffering from those disorders as well as pica if they are ingesting hair and skin as a result. Assessment for possible gastrointestinal complications, poisoning, infection, and nutritional deficiency should be done. A 16-year-old male was admitted to the hospital with nausea, vomiting, and stomach ache. Urine blood reports were normal. A small cloudy spot was identified in an X-ray of the bladder, yet an ultrasound of the abdomen was reported to be normal. A medical history was taken to determine if the patient was suffering from a bladder stone. It was learned that the patient had the habit of eating stones. This condition was not revealed by the patient, but later declared by his parents. The patient vomited a stone 1 hour after admission to the hospital. The patient was followed for 3 months and reported that he had quit eating stones. However, when the parents were questioned, they reported that he was continuing to eat stones. This is a classic example of pica. Whether it's stones, whether it's ice, whatever it might be, this behavior of eating something that's non-nutritive almost compulsively over and over may even cause some physical symptoms or problems. Those that have trichotillomania as well as pica may have large balls of hair internally, which are going to cause a lot of medical complications. So sometimes if there's a foreign object or a suspected object within the person and a history is done and they have a history of eating non-nutritive substances, this could be an example of pica. Rumination disorder. This is repeated regurgitation of food for a period of at least 1 month. Regurgitated food may be re-chewed, re-swallowed, or spit out. The repeated regurgitation is not due to a medical condition such as a gastrointestinal condition. The behavior does not occur exclusively in the course of anorexia nervosa, bulimia nervosa, binge eating disorder, or avoidant restrictive food intake disorder. If occurring in the presence of another mental disorder, such as an intellectual developmental disorder, it is severe enough to warrant independent clinical attention. One should specify if this disorder is in remission. After full criteria for rumination disorder were previously met, the criteria have not been met for a sustained period of time. This type of disorder can occur in infancy, childhood, adolescence, or adulthood. In infancy, it can be fatal. In pediatric patients, physicians are not diagnosing the syndrome early enough, and a delayed diagnosis can often be associated with morbidity. This disorder is more commonly reported in those with intellectual disabilities. It is important to rule out gastrointestinal conditions and anorexia and bulimia nervosa. Rumination disorder is frequently confused with bulimia nervosa, gastroenteritis esophageal reflux disease, and upper gastrointestinal motility disorders. Rumination disorder may cause any of the following conditions: halitosis, malnutrition, weight loss, growth failure, electrolyte imbalance, dehydration, gastric disorders, upper respiratory distress, dental problems, aspiration, choking, pneumonia, or death. The DSM also lists other specified feeding or eating disorders. This category applies to presentations in which symptoms characteristic of a feeding and eating disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate, but do not meet the full criteria for any of the disorders in the feeding and eating disorders diagnostic class. The other specified feeding or eating disorder category is used in situations in which the clinician chooses to communicate the specific reason that the presentation does not meet the criteria for any specific feeding and eating disorder. This is done by recording other specified feeding or eating disorder followed by a specific reason, such as bulimia nervosa of low frequency. There are several types of disorders that fall under the other specified feeding or eating disorder category. The first is atypical anorexia nervosa, bulimia nervosa of low frequency and or limited duration, binge eating disorder of low frequency and or limited duration, purging disorder, or night eating syndrome. The first of these in this category is atypical anorexia nervosa. This is when all of the criteria for anorexia nervosa are met, except despite significant weight loss, the individual's weight is within or above the normal range. So this is someone who has patterns of thoughts and behaviors that are very similar to anorexia nervosa, but their weight does not fall below the normal range. Also, with atypical anorexia nervosa, individuals don't show concern about their weight and body image. They're more focused on controlling their eating, and shape and weight concerns are a more recent cultural specific symptoms, such as in certain cultures, individuals may be concerned about the size or weight of a particular body part or shape of a particular body part. This may also fall under the atypical anorexia nervosa category. Here's a case study. A 32-year-old woman who has been married for 7 years is a homemaker. She has a gradual weight loss, recurrent episodes of vomiting, no menstrual period for the past 6 months, and reports that her husband is always calling her fat. An intestinal biopsy was done to rule out malabsorption syndrome, and an endometrial biopsy was conducted as well. All tests came back normal. The patient was referred for a psychiatric examination. A diagnosis of atypical anorexia nervosa was made. Bulimia nervosa of low frequency and or limited duration. All of the criteria for bulimia nervosa are met, except that the binge eating and inappropriate compensatory behavior occurs at a lower frequency and or for less than 3 months. The next one is binge eating disorder of low frequency and or limited duration. All of the criteria for binge eating disorder are met, except binge eating occurs on average less than once a week and or for less than 3 months. The next type is purging disorder. This is recurrent purging behavior to influence weight or shape. Can include self-induced vomiting, misuse of laxative, diuretics, and or other medications in the absence of binge eating. And the last one is night eating syndrome. And this is recurrent episodes of night eating as manifested by eating after awakening from sleep or by excessive food consumption after the evening meal. There is awareness and recall of the eating. The night eating is not better explained by external influences such as changes in the individual's sleep-wake cycle or by local social norms. The night eating causes significant distress and or impairment in functioning. The disordered pattern of eating is not better explained by binge eating disorder or another mental disorder, including substance use, and is not attributed to another medical disorder or to an effect of medication. Finally, we have unspecified feeding or eating disorders. This category applies to presentation in which symptoms characteristic of a feeding and eating disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet full criteria for any of the disorders in the feeding and eating disorders diagnostic class. The unspecified feeding and eating disorder category is used in situations in which the clinician chooses not to specify the reason that the criteria are not met for the specific feeding and eating disorder, and includes presentations in which there is insufficient information to make a more specific diagnosis, such as in emergency room settings. We're going to now move to a different classification of disorders in the DSM-5. These are labeled as body image and obsessive-compulsive body-related disorders. Obsessive-compulsive and related disorders are listed as body dysmorphic disorder and other specified obsessive-compulsive and related disorders. Let's start with body dysmorphic disorder. Preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others. At some point during the course of the disorder, the individual has performed repetitive behaviors such as mirror checking, excessive grooming, skin picking, reassurance seeking, or mental acts such as comparing his or her appearance with that of others in response to the appearance concerns. The preoccupation causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The appearance of preoccupation is not better explained by concerns with body fat or weight in an individual whose symptoms meet diagnostic criteria for an eating disorder. With body dysmorphic disorder, you should specify if this also includes muscle dysmorphia, and this is when the individual is preoccupied with the idea that his or her body build is too small or insufficiently muscular. This specifier is used even if the individual is preoccupied with other body areas, which is often the case. You can also indicate the degree of insight regarding body dysmorphic disorder beliefs, such as I look ugly or I look deformed. One is which good or fair insight. The individual recognizes that the body dysmorphic disorder beliefs are definitely or probably not true, or that they may or may not be true. If they have poor insight, the individual thinks that the body dysmorphic disorder beliefs are probably true. And the last one is with absent insight or delusional beliefs. This is when the individual is completely convinced that the body dysmorphic disorder beliefs are true. In the ICD-10, body dysmorphic disorder is a type of hypochondriacal disorder. Persistent belief in the presence of at least one serious physical illness underlying the presenting symptom or symptoms, even though repeated investigations and examinations have identified no adequate physical explanation or a persistent preoccupation with a presumed deformity or disfigurement. Persistent refusal to accept the advice and assurance of several different doctors that there is no physical illness or abnormality underlying the symptom. This can include body dysmorphic disorder, dysmorphophobia, which is non-delusional, hypochondriacal neurosis, hypochondriasis, and nosophobia. Other specified obsessive-compulsive and related disorders: body dysmorphic-like disorder with actual flaws, body dysmorphic-like disorder without repetitive behaviors, body-focused repetitive behavior disorder, Shubu Kiufu, Koro, and Jikoshu Kyofu. The last three are considered culturally specific syndromes, but are now listed in the DSM-5 under the other specified obsessive-compulsive and related disorder category. Let's start with body dysmorphic-like disorder with actual flaws. This is similar to body dysmorphic disorder, except that the defects or flaws in physical appearance are clearly observable by others. They are more noticeable than slight. In such cases, the preoccupation with these flaws is clearly excessive and causes significant impairment or distress. So these are actual flaws that others might notice. However, individuals with body dysmorphic-like disorder take these slight imperfections and really draw them out of proportion, so much so that they cause extreme distress and impairment for those suffering from this disorder. Body dysmorphic-like disorder without repetitive behaviors includes presentations that meet body dysmorphic disorder except that the individual has not performed repetitive behaviors or mental acts in response to the appearance concerns. Body-focused repetitive behavior disorder is characterized by recurrent body-focused repetitive behaviors such as nail biting, lip biting, cheek chewing, and repeated attempts to decrease or stop the behaviors. These symptoms cause clinically significant distress or impairment in social, occupational, and other important areas of function and are not better explained by trichotillomania, excoriation disorder, stereotypic movement disorder, or non-suicidal self-injury. Shubo Keifu is a variant of a Japanese anxiety disorder called Teijin Keiosho. This is similar to the body dysmorphic disorder and is characterized by excessive fear of having a bodily deformity. Koro is related to DAT syndrome, which is an episode of sudden and intense anxiety that the penis, or the vulva and nipples in females, will recede into the body, possibly leading to death. Teijin Keiosho, which is fear of interpersonal relations, characterized by fear of having an offensive body odor. We're going to talk a little bit about treatment of eating disorders. Typical treatment goals for eating disorders include restoring adequate nutrition, bringing weight to a healthy level, reducing excessive exercise, and stopping binging and purging behaviors. Specific forms of psychotherapy, including family-based therapy and cognitive behavioral approaches, have been shown to be useful for treating specific eating disorders. You may work in a treatment facility, or you may work in an emergency room, or in the hospital where a patient has been admitted with a specific eating disorder and may work with them specifically on these treatment goals, which may also include psychotherapy interventions. On another hand, you may work more informally with people and patients with eating disorders in clinics, in emergency rooms, and in perhaps doctor's offices. Evidence also suggests that antidepressant medications approved by the U.S. Food and Drug Administration may help for bulimia nervosa and may also be effective for treating co-occurring anxiety or depression for other eating disorders. Treatment plans often are tailored to individual needs and may include one or more of the following: individual, group, or family psychotherapy, medical care and monitoring, nutritional counseling, or medications such as antidepressants. Some patients also may need to be hospitalized to treat problems caused by malnutrition or to ensure they eat enough if they are very underweight. Complete recovery is possible. Eating disorders and co-occurring substance abuse. Substance abuse is more common in bulimia nervosa than co-occurring with anorexia nervosa. Individuals with eating disorders are significantly more likely to use stimulants and less likely to use opioids than other individuals undergoing substance abuse treatments who do not have a co-occurring eating disorder. Individuals with eating disorders experiencing craving, tolerance, and withdrawal from drugs associated with purging, such as laxatives and diuretics, may occur. Women with eating disorders often abuse pharmacological agents ingested for the purpose of weight loss, appetite suppression, and purging, such as prescription and over-the-counter diet pills, laxatives, diuretics, and emetics. Let's talk a little bit about food addiction. This idea of food addiction is a newer idea, and there is a theory that's based on food as being an addictive behavior. Problematic eating behavior is a result of an addiction to foods high in added sugar, fat, and salt. So for those that believe that food can be an addiction, they believe that the properties of food, such as sugar, fat, and salt, are key components in terms of craving and not being able to control eating large amounts of food. Animal studies show signs of addiction like binge eating tolerance and withdrawal when given access to sugar. Similarities between substance dependence and binge eating disorder also occur. Both include loss of control over consumption and the inability to reduce or stop despite a desire to do so. So the theory of food addiction is that it is similar to other substance and process addictions, and that individuals may obsess about food and then build a tolerance for either restricting or binging or purging or all of the above. And then they feel guilt, they feel remorse, and the cycle continues and begins again. The Yale Food Addiction Scale is the first that measures symptoms and provides a diagnosis of food addiction. While this type of addiction is still controversial, there is preliminary research such as these animal studies that show that certain properties in food, such as sugar, fat, and salt, can trigger responses in the brain similar to other chemicals like illicit drugs. Preliminary research on food addiction shows, for example, in a recent study, that 40 to 60% of binge eating obese patients meet symptoms for the addiction process. Obesity nor binge eating disorder is synonymous with food addiction, and indicators of food addiction are still needed. Another study found that food addiction was associated with more severe symptoms in obese participants, including elevated impulsivity, greater emotional reactivity, and more intense food cravings. Again, this is just some preliminary research on the theory of food as being an addictive substance. Here are some suggestions for nurses. Preliminary research suggests that nurses possess the following when taking care of those diagnosed with a feeding or eating disorder: having trust and commitment with your patients, empathy, support, consistency, and a non-judgmental attitude. In a qualitative study, participants said that mothering, which includes loving care and empathetic support, a surveillance and discipline role, and a constant care person, someone who is always there, are themes of the roles that nurses play in their care. While mothering, surveillance, and discipline, as well as constant care of a person, are roles that nurses play, patients suggest that themes such as trust and commitment, empathy, support, and non-judgmental attitudes are more helpful than nurses playing the role of being surveillance or the police or a more disciplinary role. These latter roles contain more judgment and therefore do not help in the process of healing from an eating disorder. So again, it is recommended that nurses are more empathetic, supportive, mothering, caring, and non-judgmental, as opposed to playing more of a discipline or surveillance role in nursing care. It's also important to keep in mind that as a nurse, working with someone with a feeding or eating disorder may be very difficult. Patients tend to be in denial, perhaps, about their disorder. They tend to be very secretive and hide their behaviors, so they have to be closely monitored. Although research shows that nurses sometimes play a surveillance and discipline role, as mentioned previously, that's not a preferable role that patients state they would like nurses to play. However, sometimes it is necessary for their health. And in inpatient settings, patients will be monitored, for example, when they're going to the bathroom, when they're in the cafeteria eating. They are not allowed to take things in and out of those areas in which they're feeding or using the restroom, because those with eating disorders tend to be very secretive. It tends to happen behind closed doors. So if you are a nurse working with an individual in let's say a hospital setting, and it's not a specific unit for eating or feeding disorders, you may have to be very careful to monitor the food intake that occurs. Is there anyone else in the room watching them eat the food, or does the food just disappear? Does someone else bring in additional food that maybe is not recommended if they're suffering from something other than anorexia, perhaps? When they're going to the bathroom, this needs to be monitored because they could get up and purge. Even if they don't have access to enemas or laxatives, they can self-induce vomiting. They can use lots of different tricks in order to be able to purge that food that they're taking. Those that work in inpatient settings will find that they have to closely monitor the weight that an individual is at, either on a daily basis or on a weekly basis. And so this will be very important. Those with anorexia nervosa and other feeding and eating disorders in which they are body image conscious will be very afraid and nervous about weigh-ins. They will become very upset if they get on the scale and they weigh more than they do the day before, even though that's the goal. So for some people with eating and feeding disorders, depending on the disorder, it can be really a turmoil to be in treatment. The goal of the provider, of the nurse, the goal of the physician, of the facility is to get this patient back to optimal physical health, which sometimes includes weight gain. Weight gain is their biggest fear. So you can imagine that there's going to be a constant struggle and battle with getting them to gain weight. Sometimes this has to happen not only with regular food, but with supplements in addition to food. Another thing that can occur, especially with those suffering from anorexia nervosa, is that they will first gain kind of in the abdomen area first, because that's where all their vital organs are, and so that's where their body is going to use that fat storage the most. And for most people who are body image conscious, having an abdomen that's expanding is something that's very concerning. So you may find resistance with a patient to eat or to keep food down, or to be sneaky and hiding their food. These are all things that you want to consider as a nurse. Again, although part of your job may be surveillance and discipline, it's difficult because that also can be a challenging role in working with these patients, because they are going to become even more sneaky and dishonest in their food intake, their food storage, those types of things. Others with different types of eating disorders and feeding disorders may be extremely picky about what they may eat. You may have to order special requests if that fits with the physician's orders. There's a lot of modifications that may need to occur if someone with a feeding or eating disorder is in the hospital trying to get back to optimal health, and there are specific food preferences that they have, or maybe even certain food restrictions that they have. So ordering food for breakfast, lunch, and dinner in a hospital setting can be more of a chore than in another unit or with other patients on the same unit that you're working on. Thank you for watching today's course on eating disorders for nursing. I hope you've learned more about feeding and eating disorders as classified by the DSM-5, as well as some helpful suggestions for nurses working with patients who have eating and feeding disorders.
This program is intended for the private use of health.edu subscribers. Any rebroadcast or redistribution without the express written permission of health.edu is prohibited.